All right. Good morning, everyone. Thank you for being here. I'm Yara Abdou. I'm from the University of North Carolina, and it's my privilege to moderate this important session on racial disparities in breast cancer outcomes and global health equity. So I would like to get started by getting our first set of poster presenters on stage, Dr. Farrokhi, Dr. Sun, Dr. Britten, and Dr. Vaynrub. All good, didn't break it. It is my pleasure to introduce our first discussant for the day, Dr. Idossa from University of Minnesota, who will start us off discussing bridging the gap and addressing racial disparities in breast cancer outcomes.
Good morning, everyone. Thank you so much for that kind introduction, and thank you to the organizers for this invitation to discuss these 4 excellent abstracts this morning. So the title of my talk is Bridging the Gap, Addressing Racial Disparities in Breast Cancer Outcomes. I'll just use this. Okay, I have no disclosures. So to start us off, I think we've made really great improvements with regards to breast cancer outcomes across many decades. But unfortunately, breast cancer disparities continue to exist. In this figure here, you see that the rate of getting and dying from breast cancer differs pretty substantially among the various ethnic and racial groups, with Black women on the left figure having a slightly lower incidence of getting breast cancer compared to white women, but a much higher mortality compared to essentially all groups. And this is related to a whole host of different issues, including biology, environment, exclusion from trials, among many other things. So I'll be reviewing these 4 abstracts today that all touch on different components of health disparities within breast cancer. So to start us off, I'll start with Dr. Farrokhi's abstract looking at racial differences in the prevalence of biomarker alterations, treatment patterns, as well as outcomes in a cohort of patients with breast cancer. So this was a study among Black and white patients in the US with metastatic hormone receptor positive, HER2 negative breast cancer who received NGS testing. They were looking at biomarker alterations as well as treatment outcomes and clinical outcomes. This was a retrospective analysis using EHR data as well as linking that to genomic data. And for their biomarker assessment, they were interested in alterations in PIK3CA, AKT1, PTEN, ESR1, as well as BRCA1 and 2. So they included over 2,300 patients in their study, of which about 13% were Black. Black individuals in this cohort were more likely to be younger, have higher grade tumors, less of them had lobular cancers. They were also more likely to live in areas of lower socioeconomic status, as well as be insured through public insurance. So in this study, as shown in that figure, they found that Black patients were less likely to have a PIK3CA mutation compared to white women. There didn't appear to be any statistically significant difference among the other alterations. Looking at first-line therapy, they also found that Black patients were less likely to get first-line CDK4/6 inhibitor therapy compared to white women, but much more likely to get chemotherapy in the first-line setting for metastatic ER-positive, HER2-negative breast cancer. In the second-line setting, there did not appear to be any difference among receipt of second-line CDK4/6 inhibitor therapy. With regards to survival, they found that the median overall survival was shorter in Black women at 34 months compared to 42 months in white patients, and this remained the case after adjusting for baseline characteristics as well as biomarkers. Among those who received first-line CDK4/6 inhibitor therapy, there didn't appear to be any statistically significant difference. although there was a slight trend towards a shorter survival in Black patients. So in conclusion, this study really does show that racial differences in gene expression likely exist, and this has also been shown in other studies, and they also show that Black individuals were less likely to receive guideline concordant care, as well as have worse survival compared to white women. But this is a retrospective analysis, and so the interpretations can be limited as the receipt of NGS testing likely varies across different ethnic and racial groups. But even when ethnic minorities get NGS testing, they're less likely to receive genotype match therapy compared to white patients. There's also a significant portion of breast cancer research, especially genetic research, that really relies heavily on genomic data that's not representative of the overall US population. And this can really impact our collective knowledge of what biomarkers are important, what genetic alterations are important in different populations. So this is shown in this study here where they looked at racial and ethnic samples in Genie, and Genie is a real-world cancer data registry designed to accelerate oncology discovery. Here you can see that the proportion of white patients in this database for essentially almost every single cancer type is overrepresented. And in contrast, when you look at this figure, you see that the proportion of Black and Hispanic individuals in this database are underrepresented. And this isn't just particular to this database. We see this if we look at GWAS, TCGA, and others. So moving on to the second abstract by Dr. Britten and colleagues who looked at socioeconomic disparities in long-term heart failure risk among individuals who are getting trastuzumab with or without anthracyclines. So this was an analysis looking at socioeconomic disparities. This is a secondary analysis, again, among patients with early stage breast cancer who received trastuzumab with or without anthracyclines. And this was also a retrospective analysis of SEER Medicare database in individuals with early stage disease, again, their primary outcome of interest being development of CHF. In their primary analysis, they included over 214,000 patients, of which about 206,000 had census data available, and that's what was included in the secondary analysis. The breakdown in a receipt of trastuzumab with or without anthracyclines are as listed there. They noted higher risk clinical features among patients who were of Black or Native American ancestry and Hispanic ethnicity. Lower socioeconomic status as well as non-English speaking households also seem to be associated with higher clinical risk features. So looking at their results of socioeconomic variables and CHF, they found in a univariate model, all of those socioeconomic variables seem to be associated with significant risk of CHF. But in a multivariate model, adjusting for cardiac comorbidities, Black patients, as shown in these figures, Black patients and those living in the lowest quartile of income seem to have the highest risk of developing CHF at 23% for Black patients and 18% higher for those living in the lowest quartile of income. Adding in socioeconomic variables did not seem to impact their prior analysis, showing that the risk of CHF was highest among those receiving both anthracyclines and trastuzumab. However, they did show that Black race and low income seem to also modify CHF risk, and so these are important considerations in this patient population. So we know that there are likely many factors that impact health, including economic, social, environmental, as well as psychosocial factors that can influence health. And these can play a significant role in the development of cardiovascular disease, as well as cardiovascular morbidity and mortality, as shown in this figure. This typically occurs by impacting pathways to chronic inflammation and even epigenetic changes. And since cardiovascular disease is the leading cause of non-cancer mortality in breast cancer survivors, this work that's presented by Dr. Britten and her colleagues, I think really highlights important areas for risk factor modification, as well as highlights the importance of incorporating social determinants of health to mitigate disparities in cardiac outcomes. Moving on to the third abstract by Dr. Sun and colleagues, who looked at physical activity and racial disparities in breast cancer survival outcomes. In this study, they were really asking 3 questions. The first was whether there was a difference in physical activity among Black and white patients, whether there was an association between physical activity and breast cancer survival, and whether that difference in physical activity could explain the difference in survival that they were seeing among Black and white patients. This was a retrospective, a cohort analysis of over 2,000 patients from a breast cancer cohort in Chicago. They linked that data with registry data as well as electronic medical record system data. Physical activity in this study was self-reported, as was the intensity of exercise. In this figure, they show the odds of having a moderate and vigorous amount of exercise prior to diagnosis during the adolescent years, as well as during their entire lifetime. And you can see that compared to European American individuals, African Americans had a decreased odds of having physical activity prior to diagnosis, as well as if you look at that third column, the lifetime vigorous activity and total activity was also lower among Black patients. Looking at physical activity and survival, they found that individuals with moderate physical activity had a 43% lower all-cause mortality and a 36% lower risk of recurrence or death compared to those who were not physically active, as shown there. In addition, they found that Black patients in this cohort had a higher mortality and a relapse-free survival compared to white patients. Interestingly, in their mediation analysis, they found that neighborhood disadvantage could predict or explain 53% of the difference that they were seeing in overall survival and 50% of the difference they were seeing in relapse-free survival. So in summary, the study shows that physical activity is important, as we've seen in multiple other studies as well, and can impact mortality as well as breast cancer recurrence. Black patients seem to show a lower engagement in physical activity compared to white patients. However, in their mediation analysis, physical activity did not seem to mediate the racial disparities seen in survival, but neighborhood disadvantage did. So the effect of neighborhood on breast cancer mortality has also been shown in multiple other studies. In this study, they were looking at neighborhood level redlining and lending bias and how it's associated with breast cancer mortality. So redlining is the systematic denial of mortgages based on place, and this predominantly inhibited the ability of Black communities, predominantly Black communities, from being able to apply and get mortgages. And in this study, they were really using this as a proxy for a measure of structural racism. And we know there's very strong associations between area deprivation index as well as previously redlined areas. So they found that in this study that living in redline census tracts were associated with an increased risk of breast cancer mortality. And interestingly, that association was stronger for white women who lived in these areas, suggesting that when white women are exposed to equivalent levels of economic, spatial, and social deprivation as Black women are, they also similarly experience poor outcomes. Moving on to the last abstract by future Dr. Anna Vaynrub and colleagues looking at allostatic load among breast cancer patients. So allostatic load is a measure of physiologic stress on biologic systems that result from chronic exposure to environmental stress. So in this study, they were looking at clinical, sociodemographic, as well as lifestyle factors that might be associated with increased risk of allostatic load. So this was a cross-sectional study of over 1,700 patients from Columbia University who completed a one-time questionnaire. Allostatic load in this study was defined as having a total sum of points that individuals received for their various risk factors listed in those systems. And high allostatic load was defined as having a total score greater than the median for that cohort. So in this figure, they show that in a very diverse cohort of patients, that Black individuals had the highest or more likely to have high allostatic load compared to other ethnic and racial groups. And in a multivariate analysis, they show that Black race and advanced stage of diagnosis seem to be associated with high allostatic load. Regular exercise actually seemed to be associated with having lower odds of having high allostatic load. So in conclusion, the study shows that Black individuals and those with advanced disease seem to be most at risk for having high allostatic load. Regular exercise seems to be inversely associated with high allostatic load, and they plan to continue to do some work to correlate this with breast cancer outcomes. So I think just to close off, a lot of us, when we think about breast cancer disparities and the factors that impact it, I think a lot of us spend some time in the downstream areas thinking about risk factors and disease and how that can impact outcomes and result in disparities. But oftentimes, I think there's a lot of more upstream structural issues that can impact where people live, the environments that they live in, the access that they have, and then determines the health status and results in the disparities that we see. I think a really helpful framework to understand was outlined by Dr. Paul Wiley and her colleagues looking at cardiovascular health disparities and showed that, or demonstrated that the downstream effects of structural systems, and they showed how those shape social position and the lived experiences of marginalized groups. And so this is mediated through policies within the social and community context. And so the everyday experience of being othered or othering, such as discrimination or implicit bias, stems from these structural determinants that can then shape that social risk. And so the chronic effects of these experiences then influence biology and subsequent cardiovascular disease outcomes through psychosocial and environmental stressors. And here they're using cardiovascular disease outcomes to use this framework, but I think we can really substitute in breast cancer or a whole host of other conditions to still use this framework to understand health disparities. So to end, I think many of the abstracts that were discussed today can really be put into context by the weathering hypothesis, which is the idea that chronic exposure to social and economic disadvantage can lead to accelerated health decline and physical health outcomes. Systemic racism really makes it so that Black and brown individuals are systematically excluded from trials, that they live in environments that increase their cardiovascular disease outcomes, that they live in environments where they cannot exercise or do not have the income, time, or resources needed to exercise. And they also disproportionately carry the burden of allostatic load that can impact their health. I think a lot of us in this room understand that race is not biologically rooted, yet the process of being racialized as Black has very real health consequences for our patients. And so I think in all of this work, it's important to keep highlighting that structural racism and not race is really the adverse factors that drives the aggressive disease biology, as well as the poor outcomes that we see in Black and brown patients with breast cancer. Thank you so much for your attention.
Thank you, Dr. Idossa, for this excellent presentation. Please feel free to send in your questions through the app or utilize the mics in the room. Okay, go ahead.
Congrats, everybody. Student Dr. Vaynrub, I hope I'm pronouncing your name right. Really interesting work, and I think one of the most challenging things in trying to come up with a scoring system is to make sure that the various points that are allocated for different aspects of the scoring system are accurate. And one of the factors going into the allostatic load is the white blood cell count. And so, are you looking at doing like a sensitivity analysis based on how that white count is, or like what level is included in the boundaries that would give someone a point or not, like maybe expanding the boundary or narrowing it, and seeing how that might affect the results? Would that go into a final analysis of this paper?
Yeah, thank you. That's a great point. That's not something that we've done yet in this work, and we're certainly in the process of kind of refining other points for our allostatic load calculation as well. But yeah, definitely there are certain considerations with metrics like white blood cell count that can be influenced by a myriad of other factors, including just patient health at baseline. If there's something transient that the patient is experiencing, that could be altering that. But yeah, definitely something to include, not something that we've looked into yet.
Thank you. I have a question for Dr. Britten. So you've showed in your study that Black patients had higher risk of developing CHF after receiving trastuzumab or anthracyclines, possibly related to comorbidities and other factors, and this has been also shown in literature. So how do you suggest we take this to clinic without introducing biases in our treatment approaches?
That's a really excellent question. I wish I had a really excellent answer for you. I think that's a good question for all of us to reflect on who are seeing patients in some of these socioeconomic groups in clinic. I think something that can be really helpful is using kind of a multidisciplinary approach, involving some of our colleagues and consultants in other departments early. And I think sometimes just checking our own biases, especially when we're seeing patients, again, that are in these certain socioeconomic groups, trying to really orient ourselves to a detailed symptom assessment in patients is a really good first step. But again, I think it's a multidisciplinary involvement from other teams. I mean, I'm coming from UCLA. We're very lucky we have a cardio-oncology division there. We have colleagues who are very interested in these sort of outcomes. But again, I think just having other members of the team who are also looking for these things are good. Thank you.
Thank you. Great answer. I have a question that came online for Dr. Idossa. So what do you think about Melissa Davis's work demonstrating that affluent Black patients retain worse outcomes?
I think that's an important question. I think certainly shows that socioeconomic status doesn't, or having a high socioeconomic status doesn't unfortunately protect Black individuals from having the same poor outcomes. And I think, again, highlights the point that disparities that we are seeing in this group is really multifactorial. And even when we take away the socioeconomic status and all of the other risk factors, Black women are still having a poor outcome, not just with breast cancer, but really with a whole host of other diseases. And so I think we have to step back and look at, well, what is the underlying driver here? Because if we can relate Black race to a lot of poor outcomes among different health conditions, then that cannot be the risk factor, right? There has to be something else that is driving it. And I think our overall understanding of, as she really beautifully explained yesterday, our understanding of even the genomic risk factors in this population and how the social factors drive that biology are not even very well understood because, again, I think our collective knowledge of those risk factors are very heavily weighted towards European ancestry. So I think there's a lot of work to do. I'm very excited about the work that she's doing, and hopefully that will illuminate some of these answers for us.
Thank you, Dr. Idossa. Take a question from Mike 1.
If you permit me to pass a comment, maybe tell a small story that buttresses what you've said. So Samuel Ogunbi, I'm a general surgeon, practice just north of Toronto in Canada. Thank you for a phenomenal presentation. Really blown away by it. So talking about how we can make a difference, I guess I just want to relate a case that I came across probably about 3-4 weeks ago that kind of buttresses what you've said. So I do colorectal cancer screening endoscopy, and I had an immigrant Black visiting her daughter in the Toronto area, and she was 65, and she had a massive, the biggest rectal cancer I've seen in a long while. And I was quite blown away. How do I start to tackle this? Obviously, she has no coverage, no nothing. And I didn't know what to do. So I spoke to her daughter, and her daughter said, you know, she's going back in a few months, but if there's anything I can do, I should do it. So out of desperation, I kind of, you know, just sent text to all my colorectal surgeon colleagues to say, you know, this is what I found. I don't know what to do, you know. Do I refer her to the tumor board? What do I do? And they all said, oh, she's going to pay tons and tons of money, but maybe I should refer anyway and see what happens. And so I referred anyway. And about a week ago, I got a phone call saying, you know, from one of the medical oncologists that actually, you know, he's wondering, should he see her, should he not see her? And I explained the whole scenario. And he said that actually there is a pathway where they can get some sort of funding assistance. It takes time to come through, but that they think they can start some kind of a treatment really for her. And he said that he's fairly confident that, you know, if they can get the ball rolling, they may be able to get a full package treatment for her. So I guess it just buttresses the fact that, you know, sometimes we feel powerless, particularly with a low socioeconomic group, but actually, you know, just taking a step forward, you know, and exactly what you said, multidisciplinary approach, reach out to everybody we know, we can sometimes make a difference. Thank you.
Thank you for this comment. Any other questions from the audience? We got a few online. So we got an interesting question, Dr. Idossa. So how can we mitigate the risk when utilizing AI in decision guidance, since its data is built through those with most ACEs to treatment, thus incurring biases?
I think that's a very interesting question and something that actually me and my colleagues spend a lot of time discussing. I think it really, so AI is going to be, it is already here, and it is going to change, I think, the way that we practice medicine and oncology. And I think it's really important as we think about designing those systems, ensuring that that the baseline data we're using to have it learn different models needs to be more representative of the general population. I think there's some really interesting studies out of Boston, for example, looking at mammography screening, and in their model, they seem to have included a very diverse cohort, and therefore that model can pick up breast cancers pretty equivalently among both Black and white patients. But I think that was an intentional decision to include a very diverse cohort of patients. I think if we don't do that and we just kind of use whatever data is most accessible or there, yes, it is going to potentially continue to widen the disparities that we see.
Thank you, Dr. Idossa. I'll give you a break, although we have a lot of online questions that you could answer. I have a question for Dr. Soon. You showed that moderate to vigorous physical activity significantly reduced mortality and, significantly reduced mortality and recurrence risk for breast cancer. Was this association independent of BMI? We know BMI is associated with exercise, and it's also associated with mortality and recurrence risk in some subtypes of breast cancer. So,
okay, thank you so much for the question. Yes, so we do adjust for body mass index, and still we see physical activity is associated with survivorship. And Dr. Sang, well, she's a first year PhD student. She cannot come.
Oh, I'm sorry.
So she's taking final exam this week. So that's the main reason. I'm the and the advisor of here. Yeah.
Well, thank you, and good luck to Dr. Sun. Take a question, last question.
So I have a comment and a question. First of all, I just want to applaud the panel. I think this work is really, really important, and important for all of us to think thoroughly about how we treat patients. But I think a lot of what I'm hearing and what some of the data is also on risk stratification with prevention. So many comorbidities, exercise, and then outcomes. So I think really it's on all of us to make sure we're also talking about that in the clinic and not just about the cancer. Recognizing there are a lot of things, like Dr. Idossa pointed out, that limit what can be implemented, but keep doing the work. My final is really a question for Dr. Farrokhi. As I listened to treatment differences, I was curious. I think you showed that up front there was a higher rate of chemotherapy compared to the CDK4/6 inhibitors in Black women. And I think this was probably published before, your work was done before, like, Right Choice came out and some of the other trials suggesting actually the CDK4/6 inhibitors may be superior to chemo in the frontline setting, but I'm wondering if you can comment on that.
Yeah, we have shown that Black patients have a lower usage of CDK4/6, and this could be a result of they are mostly under Medicaid insurance coverage, so they have less access to targeted an expensive drug. And the other thing is they are mostly under lower socioeconomic quantile. So again, this could be the other result. And but after adjusting for all of these socioeconomic status, Medicaid, or even racial difference for the biomarker, Black patient again, and it still has 40% lower access and lower usage of CDK4/6 targeted therapy. So maybe we should go further and investigate what other factor related to this lower usage, because our studies show, okay, they are under lower socioeconomic status, they have lower PIK3CA mutation, and they have under public insurance, less access to expensive drugs, but this is not the whole story. We need to investigate more factors. What are the complex interplay with this socioeconomic status, racial difference in terms of biology of disease, and the outcome of patient?
Great. Thank you.
Thank you. Thanks to the panel. There's a lot of online questions that we weren't able to address, so I encourage the presenters to try to go online and reply to those. Thank you so much. Thank you.
Thank you.
It is my pleasure to introduce our next discussant for today, Dr. Steve Kimani, who will be from University of Utah, transitioning to University of North Carolina next month. He will be talking to us about advancing global health equity and addressing disparities in low resource settings. Dr. Kimani also reminded me to ask the presenters to come to the stage. So I would like to ask Dr. Lopa, Dr. Cardoso, Dr. Kouli, Dr. Bell, and Dr. Panis to please come up to the stage. Thank you.
So first of all, I have no financial disclosures related to this talk today. And I want to thank the organizers for San Antonio 2024 for inviting me to speak on this important topic. I believe this is probably the first time that San Antonio is having a session that's focused on global health and global oncology care. So it's about time that we engage with the remaining two-thirds of the world. So some of the posters that I'm gonna focus on a study in India looking at population-based and community-led cancer screening for breast cancer. A second abstract by Cardoso et al. Is looking at improvement of access to impactful first-line treatment in low-resource settings. This is through health system strengthening. The third abstract is going to be describing characteristic of breast cancer diagnosed in Syria in the midst of a war. And then we have reports from the United States looking at a rural population and access through mobile mammography screening. And last but not least, it's really a provoking work out of Brazil looking at exposures, environmental exposures, and breast cancer. But before I delve into that, I want to use this opportunity to sort of paint us a picture of what the global health landscape looks like when it comes to cancer care delivery, cancer care outcomes, but also specifically about breast cancer. This is a map that is very striking in the disparities that exist between countries that enjoy high income status or high human development index, and those that have low human development index. And what this chart shows here is the areas that you are looking at age standardized rates of cancer as well as mortality. And I want to bring up this particular illustration looking at breast cancer. You can see that, as we know, there is a very high prevalence and incidence of breast cancer in high-income countries. But the mortality, thankfully, to decades of investment and improvement in diagnostic and therapeutics has led to improvement in mortality. You cannot overlook the stark contrast in low Human Development Index country, where while the incidence and prevalence remains lower than that in high-income countries, the mortality remains unacceptably high. And this is even going to get worse. I'm sorry to be a bearer of bad news on Friday morning, but it's projected that by the year 2045 or 2050, you're going to have a 75% increase in the burden of cancer. The burden of the top 5 major cancers, of which breast cancer is included, is going to double by 2040. When you look at how much of that increase is going to happen in high-income countries compared to low-income countries, there is such a disproportionate distribution of that increase, in the sense that here you're looking at a low-income country, and it's projected that the incidence of cancer will increase by 100%, compared to about 30% in high-income country. And this is even worse for cancers that are primarily driven by socioeconomic factors, but also other environmental and political risk factors. So moving on to our first abstract, this was a very large study that describes population-based screening. It's facilitated by a non-profit organization called the Breast Cancer Hub in the remote villages of Assam, India. The authors describe a very rigorous process where in a population that's pretty much cut off from access to cancer treatment, they knocked on 22,000 households and were able to interview participants on their lifestyle risk factors, but also identify gaps, particularly in breast cancer risk, breast cancer screening, and help develop interventions and deploy those interventions to improve screening. What I want to highlight here is that this was the survey the authors used was a general lifestyle and health behavior survey, but they asked specifically about breast cancer screening, which involved either a self-breast exam or a clinical breast exam. Of note is that no participants among these 22,000 patients or households that were contacted had ever undergone a screening test, including one of those clinical or imaging-directed screening. They identified some of the potential barriers to care, which included cost, distance, and geography. This is a remote area of India. And also lack of awareness, because there's a government-funded program that will help cater for cost of cancer care or health care, but most participants were not familiar with that program. The NGO Breast Cancer Hub was able to deploy patient navigation, patient financial assistance, transportation, and education interventions that helped improve care engagement and retention. And ultimately, they were able to have patients who had symptomatic disease undergo cancer diagnosis and treatment. The biggest limitation here is that this is a self-reported uptake of a health behavior and intervention. And there are more questions about factors relating to actual accessibility of screening tests. As we noted, most of the available imaging screening test is either mammography or ultrasound, and no participants had uptake of those. The second abstract was a study coming out of Syria, and this is presented by a hospital-based registry at one of the largest university hospitals in Damascus. This hospital treats more than 50% of cancer patients in Syria. And they reported cancer diagnosis during a year of 2023. And these were patients who underwent biopsies and molecular characterizations at this hospital. In this abstract, breast cancer was the most common cancer diagnosed, about 21%. And among the breast cancer cases that were diagnosed through a biopsy, immunohistochemistry was completed for estrogen, progesterone, and HER2 receptors. When you look at the breakdown of those cases, there were about slightly more than half were considered HER2 positive or triple negative. As we know, these are generally more aggressive and poor prognostic cancers, but also these are cancers that tend to likely present with symptoms. And so one of the things that this poster helps highlight is just the incredible resiliency of a health system amidst global conflict that has affected and decimated most of the healthcare, but they were able to still provide basic diagnostic and characterization of breast cancer. Now, the authors go on to note that there was about a quarter of those patients who had stage 4 or metastatic breast cancer, which is actually impressive because in most other parts of the world, typically advanced or metastatic cases make up the bulk of diagnosed symptomatic breast cancer. So I have to give kudos to these authors for sharing this important work. But it also raises several things. When we look at other studies in similar regions, so like Saudi Arabia, when you look at their distribution of breast cancer cases, we notice that there is a bigger proportion that is actually not lumino A type. When we look at our population in Africa, and particularly in Malawi, we also see a similar distribution. But then when we look at Chile, which is a high-income country, but not in the traditional OECD region, you see that this distribution seems to be something that perhaps is driven by screen-detected versus non-screen-detected breast cancer. And so it's possible that as diagnostic infrastructure improves in some of these regions and we're having more screen-detected than non-screen-detected cancer, that we might see a slight distribution away from these high-risk, poor prognostic cancers. But I still think that biology is still a component in this disparity. And that leads me to the next abstract, which is from the United States, but looking at a hard-to-reach or rural population. And this is something that most cancer centers, especially including my previous cancer center in the Mountain West, has done a good job of deploying in the United States are these mobile mammography screening units that help traverse wide vast of hard-to-reach places. And in this study, they reported that they were able to conduct almost 50,000 mammographies between 2008 and 2023, and this captured 20,000 unique women. What you can see here in this graph is that most of those women who are captured by this mobile mammography unit were first-time screeners. These were women who are getting their first annual mammography, compared to those who are getting their additional mammography. So this is impressive work at increasing cancer detection. They had a pretty impressive early detection rate with 80% of cases being early stage 0, stage 1 breast cancer. And for those patients who had abnormal finding on the screening mammography that warranted additional diagnostic tests, the recall completion rate was greater than 90%. That's really impressive. And I commend the authors, and I hope they share more information about how they were able to navigate, to provide patient navigation to improve this recall completion rate. And then we're going to talk about the medication access abstract. This is a unique health system strengthening abstract describing a program that is a humanitarian effort by the Humanitarian Pact, a coalition of pharmaceutical companies and non-governmental organizations that provides free access to CDK4/6 inhibitors and AI. As most of you know, these are agents that are profoundly effective at treating advanced breast cancer, but they are hardly available outside of high-resource settings. And so what this program did is provide, in addition to providing free drug, was also provide provider education and to help fill gaps in patient care, but also patient support to help improve access. They report their experience with about 200 postmenopausal women with hormone receptor positive, HER2 negative breast cancer from 11 countries. And what you can see here in this graph, these are the women who are still enrolled in the program. Vast majority of these women were from Kenya, which is my birth country, as well as Nepal. but there are a handful from other countries. And so I think this abstract helps highlight some of the country-specific barriers to program success, even where there is philanthropic effort. I also noted that there was a median time to program enrollment of 19 months, meaning from the time a woman was diagnosed to when they were enrolled in the program to be able to receive treatment. It's about 19 months. I think this is quite prolonged, and I'm sure the distribution, when broken down, it will help highlight some of these barriers that we face in working in different nations. They also interviewed patients and were able to map for us a journey map for a breast cancer patient in Mozambique. And this just helps highlight some of the prolonged and barriers to care. The last abstract, which was very thought-provoking, was looking at pesticide exposure and poor prognosis breast cancer in Brazilian women who are mostly involved in agricultural activity in Brazil. This was a case-control study with 758 participants who were receiving care at a regional public hospital. There is a lot of hypothesis generating findings from this study, including a possible link between pesticide exposure and breast cancer. The methodology of these studies were very rigorous in the sense that they were able to identify women with breast cancer and look at their exposure. The exposure was mostly self-reported at the point of this abstract preparation, but the authors informed me that they're now looking at quantitative estimates. And what they found is that breast cancer risk is possibly increased in women who've been exposed to pesticides. While the confidence interval here across the threshold of 1.0, it's still worth noting, after adjusting for BMI, menopause status, and age, it's still worth noting that these were small numbers, and I'm curious to see what a large study is able to reproduce. The authors were also able to describe gene expression assays and immunological profile of the tumors diagnosed in cancer patients who were exposed to pesticides. And there seems to be some interesting differences between the exposed and unexposed patients. I urge you to review the poster when you get a chance. So multi-level disparities of breast cancer exist, and these occur at the individual, relational, community, and institutional level, or community, societal level. And this can affect the continuum of cancer care from diagnosis through treatment retention and completion. It's worth noting that some of these drivers are cross-cutting, and others are just distinct at each level of effect. One thing that I hear and I experience a lot when I'm working in low-resource settings is the ineffective referral system, where even patients, after they've been able to successfully notice a concerning symptom and believe or have been diagnosed with breast cancer, they're still not able to receive the care in a timely manner because of loss to follow-up or ineffective referral system. The other one here is about stigma, and this came across in most studies that we reviewed today, but also competing priorities when patients are struggling with some of the basic needs such as food security, shelter, and security. Cancer or chronic diseases seems to fall in the back burner until it's too late or until it's a risk factor for disability. But I do think that we have a role as well in how we handle or include our global health partners in the research that we do. So this is a sample from 2018 looking at phase 2-3 clinical trials registered in the clinicaltrials.gov website. And you can see that only a handful were happening outside of high-income settings. So we can also do better by including our global populations in our research. And then finally, I want to highlight the risk that's emerging and unique in some of these areas, and that's armed conflict as a health risk. And we can look at our map here that shows the various areas that are engaged in armed conflict, but also look at the various effects, direct and indirect effect of war that has impact on our breast cancer population. And finally, this is a call to action to harness opportunities for interventions in global health settings, and this can be deployed at various levels. I want to highlight two particular interventions that are low cost, high impact, and that is stigma reduction and patient navigation. Thank you.
Thank you, Dr. Kimani, for this great discussion. I have the first question online for Dr. Cardoso. How did free drug access strengthen the health systems of these countries?
Thank you. Thank you for that question. Thank you also for the opportunity to present the work. I think, and it was very nicely discussed, there are many barriers besides accessibility to the treatments, to the drugs. We tend to focus a lot on the cost of drugs, and it's correct, and how that makes them inaccessible for many patients. But in certain areas of the world, even if you have them for free, as in this program, you see there's 19 months until the diagnosis of metastatic disease, until enrollment in the program. What happened in those 19 months is a huge lead time from symptoms to diagnosis. So if you look at the WHO Global Breast Cancer Initiative that divides to diagnostic interval, treatment interval, the diagnostic interval is a major difficulty and challenge in these countries. There is lack of established referral routes from the healthcare practitioner that is close to the patient and the tertiary center that has cancer care. There is difficulty in having a biopsy performed, something that nobody probably would think of, but the cost of the needle to have a biopsy of a lesion in the breast is not covered. And in certain of these countries, it is about 1 month's salary. And obviously, the patient has other priorities, such as food and housing, etc. So all these things, we need to use the drugs as an excuse to sit down with all the stakeholders of a country, those who have the power to decide, and explain that for anything to work, there is a basic infrastructure and basic resources that need to be implemented. Otherwise, once the program leaves the country, everything goes back to square zero. And so we are using this program. Of course, our goal is also to give access to the drugs, but it's very much to map the problems and help them tackle one by one.
Thank you. Lots to think about. Mic 3.
Shailaja Kamaraju from MCW Milwaukee. Thanks for the excellent session. I see a big theme here, which is access issue, whether it is in Tennessee or India or Syria or the free drug that is delivered. A comment and a question. I have good experience in mobile health programs here in Milwaukee that we published, and also overseas in India with the mobile health survivorship program for cancer patients. I think putting things in a bigger perspective, mobile health has a great advantage to provide access to patients, whether it is various domains of social determinants of health, such as transportation or reaching out to patients with cultural or language barriers, where mobile health can go to the patients, whether it is rural America or overseas. And I think mobile health has been extremely successful in screening, education, with the recent data that you presented with a great attendance to screening, like 80% attendance, I think you said, and 90% attendance for recalls too, and that's just incredible. My question to anyone of the panel members is, have you used this mobile health as an access for either genetics to test these high-risk women, or in the survivorship programs, or anything else during their cancer journey, even for detection in the United States in rural areas? Thank you.
I can take the question. So thank you very much. It's an excellent question. So we, in not this part of India where I showed the results, we haven't used because we do not have that. So in India, if you take the example of India, it's diverse, and every part of India has its own, I would say, advantages and disadvantages. So that's the reason why I know Mumbai and other places, I work in those places too, it's much more like accessible when we talk about the mobile healthcare, but I'm talking about the northeast part of India where cancer is at its peak because of the tobacco and the lifestyle system. Plus the villages we have shown here is in the Kachar district, which is extremely remote. Even the town people do not know those villages. And for any mode of transport to go there is impossible. And once we tried to do like a community screening, we had the IMA, Indian Medical Association, involved, and we said, okay, this is the day, please come for the screening, ultrasound or everything. Hardly anyone came because they're daily wage earners and they wouldn't want to leave their like $1 also that they get. And that's why we took this sustainable mode where we go door to door, and our team is from the villages themselves. It builds the trust. But what we found out was even going door to door, teaching them breast self-examination. But, as you saw, that ultrasound is not like, it's impossible to go take every woman and go to the nearest healthcare because the nearest healthcare center which provides the cancer screening is 2 hours. So we have to take 4 modes of transport to go there. So going door to door, doing the screening, that helps the most. Of course, after 40, we have to do the other modes of screening. But the next step we found the biggest challenge is who is going to take them to the hospital if they feel the lump. So because they have no one to take them to the hospital, no money, the transport. So we, from Breast Cancer Hub, we take care and accountability of every step. Our team takes the patients to the hospital, stays with the patient. We generate the income certificate. After that, the government of India aid comes in when diagnosed with cancer. But the initial, for example, $200, $300, they couldn't even think of spending. So I would say this is a framework that we tried to develop, and it is kind of now being replicated in other centers too, and which is helping because it's much more sustainable, because it's like everyone can take care of their own health. They are their own advocate. Because even if you think of the mobile system, they have to go back every year, follow up with every individual, because mammogram and ultrasound is not just a one-time thing. We have to do every year. So that's the remotest area, this is the best we could do. Thank you.
I can share with you about other details regarding the program that I'm involved with.
Absolutely, we would love to. Yeah.
Thank you. Dr. Pierce?
Thanks. I almost didn't ask my question because it's so closely related to the question. First of all, congratulations to all the investigators for the very important work that you're doing. And my thanks to the very thoughtful discussants for your discussions. So my question was really related to access, and to Dr. Bell regarding mobile mammography. Can you just briefly talk about the learning curve, and then with regard to how do you follow up, how do you ensure that patients that you find a lesion get the care they needed? We hear, door to door here, but sustainably, how do you do it in the Appalachian region?
So there was a learning curve. I believe in the one man, one task, one deadline theory, and we have a director, coordinator who oversees our mobile program. And we have an incredible infrastructure with navigators, diagnostic radiologists, an entire team. And in Tennessee, we're very blessed because we have a state-funded breast and cervical cancer fund. So if someone has an abnormal screen, these navigators and our director and her team dog these patients until they get in and get their diagnostic studies. And it also has to do with building relationships in the communities and going back to the same place year after year, and people then begin to trust us. And we're not trying to take patients out of their region. We just want them to be diagnosed and treated. There's a lot more I could go into, but in the interest of time, I'll just stop there, if that makes sense.
I'm so glad you brought the trust issue, because obviously that is a big piece. When a person has cancer, it's one thing, but if you've built up the trust in the community, it facilitates that discussion when a member of the family gets cancer. So thank you.
Thank you. Question at mic 1.
Yes, hi. Thank you. This is a great presentation. I'm really happy that everybody's starting to, or many people are starting to tackle this. I want to mention having heard Dr. Melissa Davis's presentation the other day on potentially looking at biological reasons for disparities in terms of less care, not less care, but not getting as much efficacy out of a drug or potentially having more side effects. Now, what I was curious about is I'm involved in a project for, so based on that, you would have to have certain information about a person's background, whether they are African descent, whether they're from Asian descent. So I'm currently working on a project to digitize HER2 assay. Right now, all of the slides, over 1,100 slides, came from Belgium. So I kind of asked, I said, is there any, racial or ethnic information that can maybe be used as a variable in this? I mean, you don't know if it might stratify out, and they kind of seem to say that they don't collect that information, or they're almost like not allowed to collect that information. So I'm wondering, is this common? Because obviously it would have been nice to have that, just to know, if it would stratify out. But so I'm wondering, is this common in Europe and other countries where maybe you're not allowed to ask what a person's ethnicity is or what their race is? In the United States, we can be asked. We can opt out from replying. We could just say that we don't want to say, but we are asked. So I'm just wondering, is this something that goes on in other countries?
So in Europe, there are countries that do not allow race or ethnicity to be reported, even on clinical trials. So that is true. There was a study that showed a few years back, not too long ago, over 50% of clinical trials did not even report any race or ethnicity. I think that is rapidly changing, especially with the support of the regulatory authorities like the FDA and implementing strategies for diversity in clinical trials. So we're heading in the right direction, but you're right, you bring up a very important point. Thank you.
Thank you.
Last question.
I have a question in India. What about the barrier of marriageability or marriage security and its socioeconomic impact in terms of people's willingness to come forward and get a mammogram and find out that they may have something that will make them unlikely to get married or be able to stay married? I mean, I've had that.
Yes, I know we are running out of time. So that's a great question. So irrespective of socioeconomic condition, irrespective of education, women do not come forward, unfortunately. Like in the urban sectors also I've been working. So it's very difficult. Only a handful of women who are actually practicing, they're going for the screening mammogram and ultrasound. Otherwise, it's a very difficult scenario. It's the culture, it's the taboo, and even the fear that if we are going for mammogram means we have cancer. So there are so many challenges. It is improving, but we have a long way to go. Thank you.
All right, Dr. Siva, last questions for you.
First of all, I want to thank everybody for what you're doing to make a big difference in not just cancer care in the US, but also worldwide. My question is to Dr. Cardoso about the access program. It's a tremendous effort to get free drugs, especially those expensive drugs, for free to patients, and I see the number being 265. How did you who are the stakeholders to initiate a process like that? Because drug access is not only a problem in other countries, even in here, sometimes when you prescribe these drugs, there are very high copays for patients who cannot able to, the insurance may cover part of it, but the high copays are becoming very difficult. And thankfully, pharmaceutical companies do offer free drugs through certain programs, but certain patients who are making, limited amount of money, but again, cut that threshold or go above that threshold, they cannot qualify for those free drug programs. So who are the stakeholders and how did you initiate this program and what is the future? Are you planning to expand it for more patients?
Thank you for that question. So I think most of the work goes with the Max Foundation. So the Max Foundation is working in this field for over 10 years, starting in the field of leukemia and providing for free imatinib for a particular type of leukemia. And so they have developed their own method of communicating and almost negotiating with the governments and the ministers of health to be able to donate the medication. You would be surprised on how difficult it is sometimes to give because it is considered importation, then they want taxes to be paid. So there's a lot of complexity around that. But so the Max Foundation has a very well-established system. Now, for the other stakeholders, what we were able to do is the selection of countries is mostly low income. It's not even low middle, but low income. So basically, countries that will not be a market. And for those countries, pharma accepts to donate the treatment until there is disease progression, so no shortages of the treatment. So it is not a perfect system. It works for certain areas, and that's why I said that it's, in my perspective, for breast cancer is not even the most important. It's almost as an excuse to improve the patient journey.
Thank you all for your enthusiasm for this, discussion, and thank you for the panel for their expertise.